Hello friends, let us now learn some important points about general pharmacology. In this, drug is a chemical with a noun structure that alters the pathophysiological processes in our body for therapeutic gain. So first we will see the sources of drugs. The drugs can be derived from either natural sources or semi-synthetic or synthetic. Natural sources, the drugs can be derived from plants. The drugs which are derived from plants are reserpine, physostigmine, morphine and quinine. The drugs which are which are derived from animals are insulin, growth hormone, exenatide and lepidolin. And the drugs which are derived from microorganisms are antibiotics. And there are some semi-synthetic drugs also, like if you see morphine is a natural drug, and if it is modified to form apomorphine, then we also have synthetic drugs. The synthetic drugs are mainly designed by rational drug designing. In the rational drug designing, the drug is designed to bind to a specific receptor, so that if you if the drug binds to that receptor, the normally in our body that ligand which binds to that receptor cannot bind, because drug is already because the receptor is already occupied by the drug. So that is rational drug designing. Then we have to learn about the source of synthetic drugs. So in the source of synthetic drugs, the synthetic drugs are mainly designed from natural resources by genetic engineering. So if you see, we have human insulin. Human insulin can be changed to regular insulin. For changing the human insulin to regular insulin, we will have to change an amino acid and thus impart certain qualities to the drug. So example, if you take human insulin, if you change the amino acid of the human insulin, then it forms glulisin, lispro and aspart, and thus this will cause change in the onset and duration of action. Right. Now let us now learn about the pharmacokinetics and pharmacodynamics. Pharmacokinetics is the study of pharmacokinetics. Pharmacokinetics is the study of drug movement in the body. That is, what the drug does to the body. What the body does to the drug is pharmacokinetics. What the body does to the drug is pharmacokinetics. Like, drug gets absorbed, distributed, and then metabolism of the drug occurs and it gets excreted. Then in pharmacodynamics, what the drug does to the body, that is pharmacodynamics. That is, it binds to the target and it causes effect. So first, if there is an oral drug, the oral drug undergoes redistribution. We will see later. Okay, first what happens in our body is, an oral drug, once you take an oral drug, it gets absorbed through the gastrointestinal system. Once it gets absorbed through the gastrointestinal system and goes into the systemic circulation, then this drug is distributed. And in the systemic circulation, in the liver, it gets metabolized and forms water soluble form. This goes to the kidney and this gets excreted. Now, in the systemic circulation, the drug remains. So from the systemic circulation, the remaining drug goes to the target organs and produces the effect. Now, from the systemic circulation, some of the drug undergoes redistribution. Redistribution is, it goes to the body again instead of going to the plants. So redistribution is mainly happens if the drug is very lipid soluble and very short acting. That means, for example, we will take the example of thiopentone sodium. So if you see thiopentone sodium, it is a CNS drug. Okay, it goes and in the first distribution, it goes and it gets attached to it goes to the different parts of the body, and the main site is CNS. Then it goes to the CNS, it acts in the CNS, and after just 4 to 5 minutes, it gets diffused back into the blood and redistributes to all the parts of the organ again. So as a result, the action in CNS will get stopped. So that means, because of the redistribution, thiopentone is a very short acting drug. Then if you have, the next important thing is absorption. We will learn one absorption, distribution, metabolism and excretion one by one. So absorption, in the absorption the drugs can be classified into many types based on their lipid solubilities. If the drug is lipid soluble, they can cross the membrane easily and they undergo passive diffusion most commonly, that too along the concentration gradient. Then if these drugs are water soluble drugs, then they undergo filtration through the aqueous channel. There is an aqueous channel. Through the aqueous channel they undergo filtration. So the example of this water soluble drugs are, we have subcutaneous insulin which gets absorbed through the water soluble channel. Then we have carrier mediated drug. The carrier mediated drugs, if you see, in these the drug gets attached to the peripheral receptor, and once it attached to the peripheral receptor or carrier, and then it undergoes diffusion, that is facilitated diffusion along the concentration gradient. For the facilitated diffusion, ATP is not required, and example of this drug undergoing facilitated diffusion is glut receptors. Then the drug will bind to the carrier and it undergoes active transport. This active transport occurs against the concentration gradient, so it requires ATP, and example of this drug is SGLT. Then the next important thing is, we have P-glycoprotein. The P-glycoprotein pump. In the P-glycoprotein pump, this is present on the in the intestinal lumen. So this is the blood, and here this is the lipid membrane. This membrane is the lipid membrane, and this is an intestinal cell. On the intestinal cell you will have this, which is P-glycoprotein. That is the lumen of blood. This is intestine lipid membrane, and this is intestinal epithelial cell. So this is the P-glycoprotein. Now if the drug is present, it first diffuses into the cell. Once the drug diffuses into the cell like this, and this increases the concentration of drug in the cell, and then there is effusion of drug occurs through this P-glycoprotein pump, thus causing presynaptic elimination, and it causes first pass metabolism is seen. So first we will see the drug. The drug will enter the cell through diffusion, and as the concentration of drug increases, it gets out by the P-glycoprotein pump. So this is first class metabolism. So some of the drug is lost through this P-glycoprotein activation. So this is present in intestinal lumen. So the drugs which are there are drugs which activate P-glycoprotein and that inhibit P-glycoprotein. The drugs which activate P-glycoprotein will mainly cause increased efflux of the drug, thus causing drug failure. Whereas the drugs which inhibit P-glycoprotein does not cause efflux of the drugs, that will lead to toxicity of the drug. So first and foremost we will see the examples. The drugs which activate P-glycoprotein are enzyme-induced rifampicin, and the drugs which inhibit P-glycoprotein are verapamil, amiodarone, and these include cyclosporin, itraconazole, nifedipine, erythromycin, zosequidar, and alacridar are the drugs which inhibit P-glycoprotein, that is verapamil, amiodarone, cyclosporin, itraconazole, nifedipine, erythromycin, zosequidar, and alacridar. So these P-glycoprotein efflux is responsible for causing resistance to anti-cancer drugs. Right? Next, the next important thing is about passive diffusion. So in the passive diffusion, this is here we have the intestinal lumen and membrane and blood vessel. So the membrane is separating the intestinal lumen and the blood vessel. Here this passive diffusion mainly depends upon the ionization status of the drug. So for example, if you see, this is the blood vessel, okay, that is the protein. So if the drug is ionized, and there are two things, protein always contains a positive charge. Drug might be ionized as positive charge or negative charge. If the drug has positive charge and the protein also has positive charge, then the drug is repelled. If the drug has negative charge and the protein has positive charge, the drug is attracted. So in both the cases, the drug is not absorbed because the drug is attracted or repelled by the protein. So if the drug is unionized, then it does not have any action on the protein, so it directly gets absorbed. So absorption of drug mainly occurs in the unionized state of the drug. So only when the drug is unionized, then only there is absorption of the drug occurs. So for unionization of the drug, the pH of the drug should be equal to the pH of the medium. So if you see, the maximum absorption of the drug occurs in small intestine, that is in the duodenum. We see maximum absorption of the drug, and maximum unionization of the drug occurs in stomach. So for ionization, pH of the drug should be different from that of the medium, and for unionization, pH of the drug should be same as that of the medium. For example, acidic drugs are in unionized state in the stomach, whereas basic drugs are in unionized state in the intestine. So if there is acidic drug toxicity, so in order to, like acidic drug toxicity like phenobarbital, methotrexate and aspirin, in order to get eliminated by the urine, you will have to alkalinize the urine. So if you alkalinize the urine, then these acidic drugs will undergo ionization and they get eliminated easily because they do not enter the renal blood vessel again. So if there are basic drug toxicity like amphetamine, we will have to acidify the drug, like NH4 acidify the urine. If there is basic drug toxicity like amphetamine toxicity, we will have to acidify the urine. Example, NH4Cl, vitamin C and cranberry juice. Then we have to learn about an equation which is important, which is called as Henderson-Hasselbalch equation. Henderson-Hasselbalch equation helps us to find the percentage of ionized or unionized drug. So it helps us to find the percentage of ionized and unionized drug. So if you see an acidic drug is log base 10 of unionized by ionized drug. It is unionized by ionized drug. So this is equal to pKa minus pH. Whereas if it is basic drug, then it is log of base 10 ionized by unionized drug, that is equal to pKa minus pH. Now pKa is equal to, what is pKa? pKa is the pH of medium at which 50% of the drug is in ionized and 50% of the drug is in unionized form. That is pKa of a drug is the pH of the medium at which 50% of the drug is ionized form and 50% of the drug is in unionized form. Then bioavailability is the fraction of unchanged drug that reaches the systemic circulation is called as bioavailability. Bioavailability is directly proportional to the absorption. That means if you take 100 milligrams of a drug, among the 100 milligrams of the drug, only 40 milligrams will get absorbed into the intestinal cells. From there, only 30 milligrams might get directly entered into the blood vessel if it is an oral drug. So 30 milligrams is the bioavailability. So if there is more is the absorption, more is the bioavailability, and if the concentration, first pass metabolism is more, then bioavailability will be less, right? So first and foremost, we will see calculation of bioavailability. In that, we need to know about a graph. So if a graph is plotted with x-axis, so bioavailability, if it is by oral bioavailability, it will be less than 100 because only if some amount of drug will be absorbed and it undergoes first pass metabolism. If it is an IV drug, the bioavailability will be 100%. So if you see, this is the bioavailability which is almost in the beginning, that is at the first time itself it has maximum bioavailability. So that is almost 100%. So that is for area under the curve tells us about the bioavailability, and this is the area under the curve, that is bioavailability of IV drug. Here this curve is bioavailability of oral drug. See, in the beginning there will be absorption, and once the absorption becomes peak, the plasma concentration of drug becomes peak, and then it won't be equal to this peak, because some of the drug will undergo first pass metabolism and some of the drug will not be absorbed. So this area under the curve is oral bioavailability, which will be less than 100. So if you see the formula for bioavailability, bioavailability is equal to area under the curve for oral by area under the curve IV into 100. Then we have to learn about a concept called as bioequivalence. Bioequivalence is if two pharmacologically equivalent compounds with similar rate and extent of absorption. If there are two pharmacologically equal compounds with similar rate and extent of absorption, that means with similar bioavailability, then that is bioequivalence. If the bioavailability of two drugs is almost equal, then we called it as bioequivalence. FDA criteria for approval of generic drug is bioequivalence is equal to plus or minus 20% of existing drug. For example, we have paracetamol and dolo. Paracetamol contains the main structure is paracetamol. Dolo also contains paracetamol. So for example, if you see the bioavailability of the paracetamol is 40, then the bioavailability of dolo should be on either sides of 20, that is plus or minus 20. Arbitrarily, just for understanding, if you see the bioavailability of paracetamol to be 20, then bioavailability of the dolo should be 20 to 40. These are just arbitrary values. So there should be around plus or minus 20 of the existing drug for the bioequivalence and for acceptance of the drug. Next, the next thing is about distribution. In the distribution, the first and foremost important thing is about the apparent volume of distribution. In the apparent volume of distribution, this is the total volume. This is the apparent volume of distribution is the total plasma which is required to accommodate the administered dose of drug in the whole body at plasma concentration. So that means if you take the drug and that drug requires how many ml of plasma, how much ml of plasma for accommodating the whole drug in the body, that is apparent volume of distribution. So for example, if you see there is a drug which is X drug, and that X drug is given in 10 milligram per liter. Okay, it is 10 milligram. It is given in 10 milligrams is the concentration of the drug. Sorry, is the dose of the drug. Dose of the drug is 10 milligrams, and for that 10 milligrams, when you inject into our body by IV route, it is taking the whole 5 liters of blood. So that means the bioavailability of this 10 milligrams is 5 liters. Okay, then the apparent volume of distribution of this 10 milligram drug is 5 liters. So if you take a second scenario where you are giving 11 milligrams of the drug, so this 11 milligrams of the drug will get absorbed and it gets distributed. This is a second drug. It has higher bioavailability. Okay, so it gets distributed to both the plasma, that is 5 liters, and it also goes into the different organs and also gets distributed. Okay, that means it has more volume of distribution. So you will have less drug where it reaches the target organs. So this apparent volume of distribution is the total plasma which is required to accommodate the administered dose in the whole body in plasma concentration. So the apparent volume of distribution we have to calculate based on the route of the drug. So if the drug is given in IV route, so first we will see IV route. First we will see any other route. For any other route, apparent volume of distribution is equal to dose of the drug by plasma concentration. This is equal to dose of the drug by plasma concentration into bioavailability. This is the formula for any drug. So for oral drug, bioavailable for IV drug. So for IV drug, bioavailability will be 100%. So apparent volume of distribution is equal to dose of the drug by plasma concentration. You can omit bioavailability because it is 100%. This apparent volume of distribution is important in learning about the loading dose of the drug. So for IV, if you take this loading dose, is the amount of drug which you give prior in order to reach the whole body. We will see, for example, there is a drug which is A and it has high volume of distribution, that is 1000 is its volume of distribution. Okay, you have given 100 moles of A into the plasma. First and foremost, it gets distributed in the beginning. It gets distributed into the blood, in the blood itself, and it has not reached the target organ. So for this drug, because the volume of distribution of this drug is 100, so in the beginning, if you give 100 moles of the drug first, and then because the volume of distribution is 1000, because here the volume of distribution of this A drug is high and it is 1000. So if you give 1000 moles of a drug, okay, that 1000 moles will first and foremost get distributed, and only 100 moles of the drug will be and then if you give the 100 moles, and then the 100 moles will reach the target organ. So in order to make the plasma or distribute plasma, in order to make sure that the first is distributed first, so you will have to give loading dose, that is almost equal to apparent volume of distribution. So if you see, the loading dose of the drug is equal to loading dose for IV drug. If you see, it is equal to volume of distribution into concentration of that drug, whereas loading dose for any other route is equal to volume of distribution into concentration by bioavailability. So I think you understood a little. See, there is a drug which is called as A, okay, or leave about A, we will see chloramphenicol. There is a drug which is just a minute. Okay, just take an example. There is a drug chloroquine. Okay, chloroquine causes bullseye maculopathy in the retina. It has highest bioavailability, highest apparent volume of distribution. See, because it has highest apparent volume of distribution, first and foremost, if you give the drug, okay, it gets distributed to whole parts of the body, but the action is in the eye. It won't go into the eye or any organ which is important, but it goes to the whole part of the body. For example, you are giving this chloroquine for malaria treatment, so it will have to reach the liver, right, and it will have to act on the blood, but instead of acting on the blood and liver, it directly goes to the different the whole plasma, and from there to the interstitial cells and get deposited there. Because it has high volume of distribution, it first and foremost goes and gets distributed itself, and it won't act. So for it to act, you will have to give dose which is more than the dose that it gets distributed in our body. So for example, these are just arbitrary values. If the volume of distribution of it is around 1000, okay, so 1000 moles will get distributed, right? Volume of that is the 1000 moles will get distributed in our body, in our whole volume they get distributed. Now we will have to give the concentration which should be more than the 1000 moles, right? So if the 1000 moles are distributed in our body, in the whole blood or in interstitial fluid, we will have to give the dose which is more than 1000. So what we do is, first we give a loading dose of this 1000 moles, and then we will add the required amount of required amount of dosage that is required pertaining to the disease, right? So here, if it is an IV drug, then loading dose is equal to volume of distribution with concentration, because concentration present in the plasma is important. Then if it is any other route, then we have to give loading dose is equal to volume of distribution into concentration by bioavailability. This is important, bioavailability, because all the drug which we take, if we take oral route or any other route, it won't be directly, it does not reach the, that means all the amount of drug does not reach the plasma. Only a small amount of drug reaches the plasma because of the bioavailability. Some of the drug may undergo first pass metabolism, some of the drug is not even absorbed at all. So bioavailability is very important, that should be taken into account for any other route. So these are the formulas which are obtained. Then we have the next important topic is the factors which determine the apparent volume of distribution. So there are certain factors. So first and foremost, we have lipid solubility. Lipid solubility is directly proportional to apparent volume of distribution. The more the drug is lipid soluble, easily it crosses the membranes and it gets deposited in any interstitial fluids of our body. Then fat content of the body patient is directly proportional to volume of distribution. So if more the fat content, easily the drugs can pass and they will get deposited in the adipose tissue, causing increased volume of distribution. So in obese patient there is increased volume of distribution, and in athletes you will see decreased volume of distribution, and in females have more volume of distribution than males, and elderly have more volume of distribution than young. Then plasma protein binding. Plasma protein binding is inversely proportional to the volume of distribution. For example, you have 100 moles of a drug. In that 100 moles is bound, among this 100 moles 50 moles is bound to the plasma protein, whereas 50 moles goes to the volume of goes to the close to different parts. Now this 50 moles has gone to the volume of distribution, okay, whereas this 50 moles which bind to the plasma proteins will go to the target organ. So more the plasma protein bound, then more is the availability of the drug to the tissue, and thus less is the volume of distribution. So plasma protein bound is inversely proportional to the volume of distribution. This is very important. Then we have fourth, which is tissue binding. In the tissue binding, if you see the digoxin, the drug digoxin has high affinity for skeletal muscles. The drug digoxin has high affinity for skeletal muscles. So in the digoxin, the loading dose of the digoxin is mainly based on the lean body mass. Loading dose is based on lean body mass. Then we have the next important thing is plasma protein binding. So in the plasma protein binding, the drugs, any drug, most of the drugs, not all, some of the drugs will bind to the plasma proteins. They can bind to either albumin or alpha 1 acid glycoprotein based on the property of the drug. So if you see, the acidic drugs most commonly bind to the albumin, whereas basic drugs most commonly bind to alpha 1 acid glycoprotein. So acidic drugs example which bind to the albumin, examples are CNS drugs like antipsychotics, antiepileptics, benzodiazepines, and also antibiotics like sulfonamides, penicillin or NSAIDs, aspirin. All these will bind to the acidic drugs. Then basic drugs, all these will bind to the albumin. Then basic drugs which bind to alpha 1 acid glycoprotein include tricyclic antidepressants, opioids, antiarrhythmics like lidocaine, amiodarone, beta blockers. These will bind to the basic drugs, right? So if there is rheumatoid arthritis, inflammatory bowel disease, or if there is MI, all these will increase the alpha 1 glycoprotein concentration, and thus this will decrease the free drug, which decreases the toxicity. Whereas if there is nephrotic syndrome, chronic kidney disease, or in cirrhotic conditions, there is decreased albumin, and thus this decreased albumin increases the free drug in the plasma, thus increasing its toxicity. So these are the important points about the plasma protein binding. Now after this, the next important thing is, based on this we can, based on the plasma protein binding and volume of distribution, we can tell about the drug toxicity. So in the drug toxicity, dialysis is done for certain drugs, but dialysis is not effective for certain drugs. So we will learn places where dialysis is not effective, so that the rest of the cases we can give dialysis, right? So the dialysis is not effective for drug poisoning which is caused by drugs which have high volume of distribution. Because they have high volume of distribution, more concentration of drug is in the tissues rather than in the plasma, right? If the drug is more in tissues, then obviously it is not useful for dialysis. And for if the toxic drug is high plasma protein bound, even then it cannot go to the dialysis, because the dialysis cannot filter the drug which is bound to the plasma protein. So even in that cases, dialysis is not effective. Then dialysis is also not done in the drugs which already have an antidote or irreversible binder, because it is easier to give an antidote to the patient with drug toxicity rather than doing a dialysis, right? So for example, drugs like benzodiazepines, beta blockers, amphetamine, digoxin, opioids, organophosphates and calcium channel blockers, all these are used, they have good they have an antidote, so they do not undergo hemodialysis. For example, benzodiazepine has antidote which is flumazenil, whereas beta blockers, they have antidote which is glucagon. Amphetamine has antidote, that is ammonium chloride. Digoxin has antidote which is digibind. Opioids have antidote, that is naloxone. Organophosphates antidote is atropine. Calcium channel blockers antidote is calcium gluconate. So because they have antidotes, here dialysis is not used. So this is about the plasma protein binding and bioavailability. In the next class we will learn about the metabolism of the drug. Thank you for watching.